Welcome to the Emirates Society of Emergency Medicine Emergency Ultrasound Lecture Series. My name is Rasha Buhmaid, and I'm going to be talking to you about Extended Focus Assessment of Sonography in Trauma, which is also known as EFAST. Let's start up with a case. This is a 24 years old male brought in after a motor vehicle crash. He was a restrained driver driving at 60 miles per hour and was brought in by medics. He was intubated at the scene because of GCS of 6 and brought in intubated to you, immobilized with a C-spine collar and a backboard. This is a common occurrence in the emergency department where trauma patients present and there's not readily available apparent injuries on physical exam. Furthermore, the presence of distracting injuries, altered mental status, or intoxication may significantly reduce the sensitivity and specificity of your physical exam findings. Therefore, further diagnostic studies are indicated. So in this patient is already brought in intubated, with a concern that this patient could have a significant head injury. And you need to rapidly evaluate for possibilities of multi-trauma or other injuries to involve consulting services on board. So this is where the extended FAST exam can be readily available and help rapidly expedite the evaluation of this patient. The objectives of this talk is to review the indication of an EFAST exam, how to perform the exam, review some normal scans, and some pitfalls for performing the EFAST. German and Japanese physicians have reportedly been using ultrasound in trauma setting since the early 1970s, and this is one of the early papers that were published. However, it did not gain favor in the US until the 1980s. In the past, diagnostic peritoneal lavage, or DPL, was used to look for intra-abdominal bleeding with a sensitivity of 87 to 96% for the bleed. It should be noted that up to 30% of trauma patients with a positive DPL eventually have a negative laparotomy, as there is a high false positive rate for DPL. In the 9th edition of the Advanced Trauma Life Support, they have incorporated important changes. These changes include the increased emphasis on the FAST examination, and diagnostic peritoneal lavage is now optional. The FAST exam has replaced the DPL in this role because the FAST is less invasive, safe in pregnancy, and does not carry any of the complications associated with DPL. The indication of an EFAST exams are three very important ones. First, in blunt and penetrating cardiac trauma, in blunt abdominal trauma, and blunt and penetrating chest trauma. It's very important to understand that when you perform an EFAST exam, you're trying to answer four important questions. First, is there intraperitoneal hemorrhage? Is there a traumatic pericardial effusion? Is there a hemothorax? And is there a pneumothorax? This is a very important point to emphasize, that you're not looking to make a diagnosis of what is the actual injury. You're not looking for the liver laceration, splenic laceration, bowel injury, but you're specifically looking for signs of significant injury, including hemoperitoneum, traumatic pericardial effusion, hemo or pneumothorax. In the next few slides, we will be talking about how to perform the exam. So first, with probe selection. The curvilinear probe, or the abdominal probe, is the most commonly available probe in most of the emergency department, and that can be used for performing the EFAST exam. It has its own advantages and disadvantages. The advantage is that it has a wider and clearer image, as well as a better tissue penetration. But the likelihood of an obstructing rib shadow is higher, and sometimes can make imaging harder. An alternative is to use the phased array probe, as the transducer can fit between the intercostal spaces, and that makes the image easily obtainable without any obstructing rib shadow. When performing the FAST exam, the patient is lying supine. You're going to need to obtain 4 different views and interrogate 10 potential spaces for evaluating for any significant injury. We'll start with the right upper quadrant. In the right upper quadrant, you're going to interrogate 4 important spaces: the pleural, the subdiaphragmatic space, hepatorenal recess or Morrison's pouch, as well as the inferior pole of the kidney. Let's review some anatomy. This is a slice from a normal CT scan that we're going to highlight the important spaces that you want to interrogate. First is the pleural cavity, so the space just above the diaphragm, the subdiaphragmatic space, the hepatorenal space or Morrison's pouch, as well as the inferior pole of the kidney. In order to obtain a good right upper quadrant view, the probe is placed at the mid-axillary line between the 8th and 11th ribs. The probe is placed at an oblique angle, such that it will fit in between the intercostal spaces, and the probe marker pointing cephalad towards the posterior right axilla. Note in the video that once you're going to try and rock and fan the probe in order to obtain an adequate image. The resulting image should include the liver, the kidney, the diaphragm, and you should be able to evaluate 4 potential spaces, including the pleural space, the subdiaphragmatic space, the hepatorenal space, and the inferior pole of the kidney. This is an example of a normal right upper quadrant view. You see, the sonographer is interrogating all 4 spaces mentioned earlier in the ultrasound image. If you look at the sonographer's hand, the sonographer is fanning superiorly and inferiorly, as well as moving the probe cephalad and caudad in order to include all 4 potential spaces. So remember, this is not a still image. It's a dynamic study where you're trying to evaluate all 4 spaces. Whether you're in the right upper quadrant or left upper quadrant, you should be able to evaluate the pleural cavity. And in order to evaluate the pleural cavity, you need to look for 2 important signs: the mirror image artifact and look for a spine sign. We'll talk first about the mirror image artifact. Looking at this video, the diaphragm is this white line just above the liver, and looking above the diaphragm is the lung. In the ultrasound image, the lung appears like the liver. This is what is known as a mirror image artifact. Because we know by anatomy that the composition of the liver is way different than the lung. The lung is air-filled while the liver has tissues. And the ultrasound has specific physics that makes this artifact. And this artifact is very important when you evaluate the pleural cavity. The diagram is going to explain the physics behind the mirror image artifact. The mirror image artifact is seen when the ultrasound beam is faced by a highly reflective surface in its path. But instead of directly being received by the transducer and being reflected back to the transducer, it encounters another surface. For example, the liver in the right upper quadrant, and then it reflects back to the diaphragm and then goes back to the transducer. There is a technical false presumption that the returning echo has been reflected once, and hence the delayed echoes are judged as being returned from a deeper structure, thus giving the mirror image artifact on the other side of the reflective surface. So this is the still image that represents that. So if you see the liver and the lung look exactly the same because of the mirror image artifact. The second important sign to evaluate when looking at the pleural cavity is the spine sign. Normally, the lung tissue is occupied by air and therefore limit the penetration of sound waves down the spine. So you will see the spine extending to the diaphragm only, and you can't see the reflection of the spine above the diaphragm because of the air in the lung limiting the ultrasound wave penetration. But when there's anything other than air occupying the lung, there is clear visualization of the vertebral bodies located above the diaphragm. And this is what is known as the spine sign. So on the left, you can see the normal spine ends at the level of the diaphragm because the lung is occupied by air, limiting the ultrasound penetration. While when you have anything other than air occupying the lung, you would see the vertebral bodies above the diaphragm. This is made possible by pleural fluid or hemothorax in the setting of trauma, acting as an acoustic window for the ultrasound beams. So this is on the right side a positive spine sign. And in the setting of trauma, you're concerned that this patient has a hemothorax. Let's go through some examples. So what do you think of this right upper quadrant view? So you can see there is anechoic or black fluid collection between the interface between the liver and the kidney at the Morrison's pouch, indicating that there is free fluid in the abdomen. How about this image? This is also the right upper quadrant. You can see the liver and the kidney, and you can see this anechoic or black fluid collection just at the inferior pole of the kidney. That's why it's very important to fan up and down and interrogate all four spaces when you're looking at the right upper quadrant view. This is another example of a right upper quadrant. So what do you think? So in this video, you can't really see the interspace between the liver and the kidney. But what you can see is that above the diaphragm, that there is anechoic fluid collection. And you can see that the spine vertebral shadow is extending above the diaphragm, indicating that there is fluid collected in the pleural cavity, and in the setting of trauma, you're concerned that this is a hemothorax. But I can't use this video to evaluate the intraperitoneal cavity because you don't see all four potential spaces. But it's definitely positive for fluid in the thoracic cavity. Just a quick review, what a normal right upper quadrant looks like, and in comparison when you have the positive spine sign extending above the diaphragm. How about this image? So in this image you can see very small amount of free fluid in Morrison's pouch, as well as the extension of the spine sign above the diaphragm. So there is fluid in both spaces. It's very important to understand that if you perform this exam very fast, you might not be able to pick up small amount of fluid. Therefore, it's important to have very steady hands and interrogate all the potential spaces and evaluate them very well. How about this video? I'll give you a few seconds to look at it. So in this video, you can see a small area of hypoechoic just at the Morrison's pouch. It doesn't appear anechoic or black where you can say that this is free fluid, but this is definitely not normal, indicating that this is a potentially clotted blood rather than fresh blood. So this is an important pitfall that you might call normal if you don't interrogate and evaluate the area very well. So on the left side is what anechoic free fluid looks like. This is when you have fresh blood. On the right side is hypoechoic clotted blood. And if you don't concentrate and evaluate the area well, you might miss it and call it a negative study. How about this video? What do you think? Is this a positive or a negative study? So looking at this video, this is perinephric fat. So perinephric fat is another pitfall that can commonly cause confusion when you're ultrasounding the right upper quadrant. Fat in the perinephric area creates an echogenic space between the kidney and the liver and can be mistaken for organized clotted blood. It can usually be distinguished from the hemoperitoneum because it has more homogeneous echogenicity than a hematoma, and the perinephric fat is adherent and has no motion with respiration, in contrast to hematoma that can move independently of the kidney. So in this, I placed the prior example of the clotted blood next to the perinephric fat in order to be able to distinguish both of them. So far, we have discussed the first view, which is the right upper quadrant view, and we went through the 4 potential spaces in the right upper quadrant that you should look for free fluid evaluation: the pleural cavity, the subdiaphragmatic, the hepatorenal or Morrison's pouch, and the inferior pole of the kidney. The second view is the left upper quadrant. The 4 potential spaces in the left upper quadrant that you should evaluate is again the pleural cavity, the subdiaphragmatic space, the splenorenal space, and the inferior pole of the kidney. Let's review some anatomy. So this is again the CT scan image, and the 4 potential spaces you want to evaluate here is the pleural cavity, the subdiaphragmatic space, the splenorenal space, as well as the inferior pole of the kidney. In the left upper quadrant, the most sensitive part for fluid collection is the subdiaphragmatic space, in contrast to the right upper quadrant, where you want to look at the hepatorenal recess and the inferior pole of the kidney. So how to obtain the left upper quadrant view? Remember the anatomy, the spleen is smaller than the liver. So the left kidney is more posterior and superior than the right kidney. Therefore, the starting probe position on the left should be in the posterior axillary line in the 5th to the 7th intercostal space. Again, the probe marker should be pointed cephalad towards the patient's head or left axilla. As with the right upper quadrant view, the probe's orientation may be rotated slightly to an oblique angle in order to place the probe parallel to the ribs and to sit in between the rib spaces, and the plane of the ultrasound beam might cut through fewer ribs. It is important to slide the probe superiorly and inferiorly to fully investigate the space between the diaphragm and the spleen, as this is usually the first space where fluid will collect. Again, fan the probe anteriorly and posteriorly at each probe position as the probe is moved from superior to inferior in order to interrogate the 3-dimensional structure and evaluate all potential spaces. The representative image of the left upper quadrant should include the kidney, the spleen, and the diaphragm, and you should be able to evaluate the 4 spaces: the pleural cavity, the subdiaphragmatic space, the splenorenal space, and the inferior pool. I just want to point out, when you evaluate the pleural cavity, it's the same principle that applies from the right upper quadrant that we discussed earlier to the left upper quadrant. So you want to look for the mirror image artifact as well as the spine sign when you evaluate the pleural cavity. Let's go through some examples. What do you think of this video? So this is a normal left upper quadrant view. You can see the spleen, you can see the kidney and the diaphragm, and the sonographer is fanning throughout the structures, and there's no evidence of any anechoic or black fluid collection in the subdiaphragmatic space, in the splenorenal space, or the inferior pole of the kidney. As well as the pleural cavity also looks nice and clear. There's normal mirror image artifact as well as the spine ends at the level of the diaphragm. So this is a normal left upper quadrant view. I can't emphasize enough that it's not a still image. You have to dynamically evaluate all spaces. Therefore, fanning and moving cephalad and caudad is very important. How about this video? So in this video, you can see that there is anechoic fluid collection in the subdiaphragmatic area just above the spleen. So definitely there's fluid in the abdominal cavity, and there's also potentially maybe fluid in the thoracic cavity, although the sonographer doesn't really interrogate and evaluate that area very well, but I would definitely be suspicious that there is also fluid in the thoracic cavity from this video. How about this video? Take a few seconds. So you can see that there is anechoic or black fluid collection in the subdiaphragmatic space extending to the splenorenal space. That's why it's very important to evaluate all potential spaces. And like I said, in the left upper quadrant, the subdiaphragmatic space is the most sensitive and the first area that fluid will collect in the left upper quadrant. This is another case. What do you think of the findings? Again, this is the left upper quadrant view. You can see the kidney and you can see the tip of the spleen. And there is anechoic fluid collection, very small amount just at the tip of the spleen extending to the splenorenal space. So if you don't really evaluate the area very well or you scan very fast, you might miss that. But remember, any fluid collection is usually anechoic and black, and they usually have these triangular appearances, making you highly suspicious that this is free fluid in the abdomen. How about this image? So this is the left upper quadrant view. You can see, probably to optimize this video, you might be able to adjust the depth and decrease it because you can see there is space that you're not really using. But what is apparent here is the spine sign. You can see that the spine extending above the diaphragm, making us suspicious that there is something other than air occupying the lung. And in the setting of trauma, you're concerned that this could be pneumothorax or sometimes pulmonary contusion. Fresh pneumothorax will appear as anechoic, which I can't really see any black anechoic fluid collection, but this also could be pulmonary contusion. What do you think of this image? So this is a normal left upper quadrant view, and it's a very common pitfall that the stomach is mistaken for free fluid. Looking at the image again, when you're scanning more superiorly, the interface between the stomach and the kidney, You might mistake the stomach by the spleen and the free fluid in the stomach as free fluid in the abdomen. So the way to differentiate between fluid in the stomach and free fluid in the abdomen is fluid in the stomach is usually surrounded by the walls of the stomach, so you won't really see that triangular fluid collection in the interspaces that we discussed earlier. So it's very important pitfall, and to avoid that, place your probe more posterior in order to evaluate the spleen and the kidney rather than the stomach and the kidney. How about this video? What do you think? Is this a positive or a negative study? So this is a renal cyst. Renal cysts can be mistaken for free fluid because this renal cysts are filled with anechoic fluids, but usually they are cystic and circular in structure. I can tell you that this is not an adequate full evaluation of the left upper quadrant because you don't see the sonographer fanning through all of the spaces, but many sonographers can mistake the renal cyst as positive free fluid in the splenorenal recess. So it's an important pitfall to be aware of. So differentiating renal cyst from free fluid, I just placed the videos side by side to understand the difference. So the cystic fluid collections are less likely to be free fluid. On the right side of the screen, you can see an example of free fluid, and you can see the triangular sharp edges where these fluid collection will form, and that's not seen when you have cystic fluid collection. So it's important to differentiate between both of these. So far we discussed two views. We discussed the right upper quadrant view and the left upper quadrant view, and 8 potential spaces. 4 spaces in the right upper quadrant and 4 spaces in the left upper quadrant. Remember, the most sensitive part for fluid collection in the right upper quadrant is the hepatorenal recess and the inferior pole of the kidney, while the left upper quadrant is the subdiaphragmatic space. The next view we will discuss is the suprapubic view.